Good afternoon. I'm joined today by Jason Miller, who's a student at McGeorge School of Law, my alum. And this particular bill comes out of McGeorge School of Law's legislative clinic process. So I'm pleased to present the bill here today, Mr. Chair and members. This is AB 791 relating to advanced health care directives. And advanced health care directives are, of course, very important expressions of the wishes of an individual for how they wish their own care to be directed in a health crisis. So it's a way to memorialize what they would like, what their personal preferences are, so if they become unable to speak or participate, they've memorialized it someplace. And this raises the issue of then how do those loved ones, those family members, understand what that directive was and how this kin wished to be handled. Currently, the Secretary of State maintains registry of hard copy advanced health care directives that can be made available upon request by a registrant's health care provider, public guardian, or legal representative. And so then if such a request is made, received by the Secretary of State, the advanced health care directive will be copied and faxed to the inquiring party. So it's sort of a paper-based system that's got to go through some hands to get this out to the people inquiring. And this offline process creates delays that in a moment of crisis maybe seem as immense hurdles to get in care in accordance with the wishes of the person in crisis. To ensure families have ready access to a family's advanced health care directive, this bill would have the Department of Health Care Services in developing the state Medicaid Health Information Technology Plan to develop a process for managing advanced health care directive information electronically. And I would like to, if I may indulge the committee, ask Jason Miller. This bill came out of a McGeorge Law School process. If he may address the committee briefly, Mr. Chair.
Of course.
Thank you.
Good afternoon, Chairman Bonson, members. Like Assemblymember Cooley said, my name is Jason Miller. I'm a student at McGeorge School of Law in the Public Policy and Legislation Clinic. As Assemblymember Cooley said, advanced healthcare directives are important documents, and becoming more and more so every day as advances in healthcare practices occur, and everything becomes much more complicated in terms of what options are available for people in their end-of-life situations. The paper-based process is no longer utilized very much and is, as the Assembly member said, very clumsy. We interviewed several doctors in coming up with this proposal and coming up with this plan, and doctors suspected emergency situations were basically unanimous, and what they wanted was something that's immediately accessible to them in a system that already exists. They don't want to have to log out of their computer and log into a separate database. They don't want to have to make a phone call and see if their patient has an advanced directive or not. They want something that's right there. We seize this opportunity to currently the state is implementing, along with the federal government, the electronic health database that would have it's moving health records from into an online platform that would be accessible throughout various health provider systems. What this bill will do is include advanced healthcare directives in the system and make it flagged very quickly for a doctor that can see exactly what the wishes of the patient is, ensuring high-quality end-of-life care. With that, I'd like to thank the committee for your time.
Thank you, Jason. Good job.
Thank you. Excellent job. Additional witnesses in support?
Yes. Mr. Chair and members, Tim Madden with the California chapter of the American College of Emergency Physicians, and I think Mr. Miller from McGeorge outlined the reasons why emergency physicians is important to have access to advanced health care directives, and we're in support. Thank you.
Very good.
Additional witnesses in support? Witnesses in opposition? Seeing none, any questions from committee members? Assemblymember Ridley Thomas.
Yes, Mr. Cooley or Mr. Miller, are there other states that have adopted this? Is there a federal dialogue about whether or not this will be a part of what CMS adopts or their best practices, NIH, large research, governmental thoughts on how widespread this adoption might be?
Do you know if other states have adopted it, Mr. Miller?
Not statewide. There is a Manhattan County in New York pilot project that's working on it. It was considered as part of the latest rounds in the federal implementation, but was tabled at this time to be a federal mandate.
Yeah, and I think the federal question is an important one, as I have learned in the course of bringing this measure forward. The federal issue is an important one, how it interacts with federal law.
Could a locality on its own enact this? Is that allowed, or?
I'm not sure. I would think not. I think the nature of the evolution of healthcare, probably a single locality in California would be hard-pressed to do it. It would probably be an interference with things. And you'd lose the efficiency. I mean, ultimately, I think the big idea that this bill represents is in a state the size of California, if we can eventually, in concert with federal law, as the health system is evolving, get these online, anyone could track them down and access it. So if you do it it would be sort of balkanized. This place, you sort of have to know, now which stone do I turn over? And at this moment of crisis, you're not really thinking that way.
Okay. Thank you, Mr. Chair.
Assemblymember Wood.
I'm just, and thank you for bringing the bill. Thank you, Mr. Chair. I'm just curious, how does the information going to be gathered? I mean, I know I just recently updated my healthcare directive, and I kind of personally consider that a private family document. And so I guess I have concerns about that document potentially available to other people to view, as this, I consider this a personal family decision.
Yeah. Well, at this moment, these are filed with the Secretary of State, and there is a method for accessing from the custody of the Secretary of State, so the health care provider, family member, there is a method currently. So using technology to access it, which is what this bill is about, this is just speeding up the information cycle, so there'd have to be safeguards built in. But currently, as I understand it, these are filed with the Secretary of State, and there is an ability for persons to reach out and get a copy of one of these that has been filed and have it faxed or transmitted electronically in some form to healthcare provider, the family member.
Thank you.
So this is sort of speeding. This is just created an electronic cycle to speed up what is now sort of a paper-based getting information out, and in this sense responds to sort of someone's in a healthcare crisis. People want information now, but it was definitely needs safeguards, and I think in this. Anyway.
Okay. Thank you.
Yes. I want to thank the committee for their outstanding collaboration in working through this issue. And I'm a McGeorge alum. This grows out of that educational process. I was happy to say I will champion this measure, but it's not a field in which I have particular expertise. And Mr. Chair, you have some counsel.
Yes, Assemblymember Cooley. First of all, I just want to thank you, Assemblymember Cooley, for your leadership, to all the law students for your hard work and your advocacy and your leadership as well, and your collaboration together. I do agree that we need to streamline and modernize the process by which doctors receive important information about a patient's medical care wishes through an advanced healthcare directive, and I want to acknowledge the hard work that the sponsors have done. I think it's a very well-intended bill, and I think it has excellent potential. I do think there's some unintended consequences that create concern for me, and the analysis raises some of those, so we've shared them through the analysis, and I'll just go over a couple of them real briefly. One, what do we do about the existing Secretary of State system? Two, I think it's a good idea to have an agency involved in health administer the program, but not sure it should be DHCS. Three, to the bill's credit, it builds on an existing IT system instead of creating a new one out of whole cloth. But the one referenced in the bill is for providers. And I don't know what kind of issues, especially security issues, are raised by opening it up for individuals to use. And then the last and perhaps the biggest issue is that as was alluded to by Assemblymember Cooley, the system that you're talking about in the bill was paid for with federal matching funds. And I'm afraid that adding another function onto the system would make us ineligible for federal funds going forward. And of course, that's an important revenue stream for us. So I'll say those are my concerns. They're significant, but not unresolvable. And so I think we can solve those problems. I just don't think we can solve them today in this committee. And my suggestion, with respect, is that you consider making this a 2-year bill, Assemblymember Cooley.
Happy to. I want to. The committee has been excellent, so I thank you for the opportunity to have this hearing. I'd be delighted to do that. I think we need to ask the feds, the follow-up question: do they see a way we could thread the needle, deal with this under their existing system, and then work through the other practical California-based considerations? So no, that's a fine outcome. We advance in stages in this business, and this is a good stage.
Thank you, Assemblymember Cooley, and thank you to the students.
Very good.
Thank you.
Thank you, colleagues.
Just a reminder that we take our bills in file item order. And next in order is file item 16, AB 1117, Assemblymember Cristina Garcia.
Thank you. Committee members, I will keep it really short. AB 1117 would bring additional resources to stretch medical systems to help improve California's vaccination rates for our 2-year-olds. And I will actually hand it over to our witness today. Lord, I guess it's on here.
Hi, I'm Kelly Hardy with Children Now. We're the sponsor of the bill, and I want to thank Ms. Garcia for authoring this important measure, which would bring additional resources into the healthcare system to help improve California's low vaccination rate for 2-year-olds, as she mentioned. This is intended to be a win-win-win for plans, providers, and kids. And we appreciate the questions raised in the analysis and look forward to working to resolve those issues.
Thank you. Additional witnesses in support?
Beth Capellan on behalf of Health Access California in support.
Tim Shannon representing the Children's Specialty Care Coalition in support.
Lydia Bourne representing American Academy of Pediatrics. We are in support.
Bernadette Ariano representing the California Children's Hospital Association, also in support.
Amber King with the Association of California Healthcare Districts, also in support.
Judy Darnell representing United Ways of California in strong support.
Sean South on behalf of the California Primary Care Association in support.
Justin Garrett with the March of Dimes in support.
Greg Herner on behalf of the California Healthcare Institute in support.
Kimberly Chen with the California Pan-Ethnic Health Network in support.
Thank you.
Thank you. Additional witnesses in support. Seeing none. Any witnesses in opposition? Seeing none. Any questions from committee members? We have a motion but no second. The committee can entertain a second. All right, we have lots of seconds now. Thank you.
I heard a second earlier, actually.
Maybe we missed it. So we definitely have one now. Assemblymember Garcia, would you like to close?
I respectfully ask for your aye vote.
Thank you for bringing this bill forward. We have a motion. We have a second. The motion is due pass to appropriations. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Mainshine, aye. Bonilla? Bonilla, aye. Burke? Burke, aye. Chavez? Chavez, aye. Chu? Gomez? Gonzalez? Hernandez? Lackey? Nazarian? Patterson? Patterson, aye. Ridley Thomas? Aye. Ridley Thomas, aye. Rodriguez?
Aye.
Rodriguez, aye. Santiago? Steinnorth? Aye. Steinnorth, aye. Thurmond? Aye. Thurmond, aye. Waldron? Wood? Aye. Wood, aye.
Your bill passes 11-0. Congratulations. Next, we have item number 20, AB 1162, Assemblymember Holden. Thank you for your patience, sir. Excellent strategic move.
Mr. Chair and members, let me start by accepting the committee's technical amendments. We appreciate that input, and we look forward to moving along today, recognizing those changes. Today I present Assembly Bill 1162, a bill that will fight tobacco dependence and save health care costs for California. AB 1162 clarifies which tobacco cessation treatments are covered under Medi-Cal to ensure the coverage is comprehensive. Smoking is the leading preventative cause of death in the United States, but in the Medi-Cal population, the risks of smoking are even higher. The national smoking rate is 18%. However, the smoking rate within the Medicaid population is 30%. There are effective medications to help smokers quit, but this population has significant barriers to health care, including long wait times for appointments and decreasing number of primary care providers. This body is considering ways to discourage people from smoking, but we should also help them quit. AB 1162 does that. Specifically, the bill requires that all 7 FDA-approved medications and all 3 types of counseling are covered. It also requires that there are no barriers to these treatments. This is in line with the federal government and the California Department of Health Care Services are directing health plans to do. I understand there are concerns that the removal of certain barriers will raise costs, but research has shown that the long-term savings of comprehensive coverage outweigh initial costs. This bill is based on proven medical science and economic research. For these reasons, I respectfully ask for your aye vote.
Thank you. Witnesses in support?
Thank you. Callie Hampt on behalf of the American Heart and American Stroke Association, proud co-sponsor of AB 1162. This bill provides clarity to health plans, patients, and physicians regarding tobacco cessation services that would be covered for all Medi-Cal patients. Tobacco-related diseases are the leading cause of death in California, claiming more than 40,000 Californians annually and costing Medi-Cal roughly $3.5 billion in taxpayer dollars to treat tobacco-related disease. This bill, based off clinically proven effective methods in treating nicotine addiction, is based off federal guidance to states accepting federal dollars to expand their Medicaid programs. This bill would keep California in compliance with ACA expansion laws by ensuring comprehensive coverage be made available to enrollees in both fee-for-service and managed care plans. Other states are already currently doing this, including Massachusetts, and in 2006, they made comprehensive cessation services available to their enrollees and saw a dramatic decrease in the Medicaid smoking rate from 38% to 28% in just 2 years, saving the state over $10.5 million in healthcare-related costs and amounting to a $3.07 return on investment per dollar spent in the cessation program. Addiction to tobacco is a costly and difficult habit to break, and ensuring comprehensive access to those wishing to quit on Medi-Cal is a sensible solution with the ability to save thousands of lives and millions of taxpayer dollars. Therefore, I respectfully ask for your aye vote.
Chair and members, Autumn Ogden with American Cancer Society. Cancer Action Network, also a proud co-sponsor of 1162. As you know, smoking is a difficult habit to quit and takes many quit attempts, which is why the federal government has made tobacco cessation one of the requirements of the Medi-Cal expansion and provided clear guidelines on how to implement this requirement. Part of the guidelines provided recommended coverage of all 7 FDA-approved cessation medication when prescribed by a physician without prior authorization. The elimination of the prior authorization requirement removes an extra barrier in accessing timely treatment. The elimination of this requirement also acknowledges that the prescribing physician is capable and qualified in determining which of the FDA-approved drugs are most appropriate for their patient. When trying to quit, it is essential that we remove as many barriers as possible to achieve greater success. By codifying these federal guidelines, AB 1162 achieves this goal. Thank you.
Good afternoon, Lindsay Freitas with the American Lung Association in California. Every year, our association puts together a report that looks at all 50 states in 4 key tobacco control areas. One of those areas is tobacco cessation. Specifically, we're looking at whether or not there are barriers to access for cessation treatments, and currently our state receives a D grade, which is really sad. Furthermore, we also look at the helping smokers quit and found that in California, we have barriers to access of cessation services that vary by plan. We really need to ensure that all Medi-Cal recipients receive the services they need to quit smoking without these barriers. A 2010 CDC study showed that 69% of adult smokers wanted to stop smoking, 52% had tried to do so, but only 6% had actually quit. We really need to make it as easy on them as we can. Thank you.
Thank you. Additional witnesses in support?
Jerry Jeffy, representing the California Chronic Care Coalition. We are in support of the bill.
Justin Garrett with the March of Dimes in support.
Sebastian Aldaz on behalf of the California chapter of American College of Emergency Physicians. We are in support.
Eduardo Martinez, California Medical Association, in support.
Jimmy Jackson, Biocom, in support.
Elizabeth Landsberg, Western Center on Law and Poverty, in support.
Greg Herner on behalf of the California Healthcare Institute, in support.
Additional witnesses in support? Seeing none. Witnesses in opposition?
All right. 11 against 1. I like those odds. Mr. Chair and members, Nick Luizos on behalf of the California Association of Health Plans. Regrettably, we do oppose AB 1162. We believe this bill will increase costs to the state by requiring Medi-Cal managed care plans to pay for tobacco cessation drugs in a manner that is inconsistent with the Department of Health Care Services policy and sound medical management. To be sure, health plans strongly support the importance of aiding individuals in tobacco cessation, and we recognize the staggering economic impact and the human consequences of smoking. That is why the department requires Medi-Cal plans to cover the panoply of tobacco cessation drugs, but with reasonable medical management, such as prior authorization under certain circumstances. Unfortunately, we do have several concerns with the bill. Number one, the measure requires Medi-Cal managed care plans to cover all cessation medications approved by the FDA and correspondingly eliminates prior authorization requirements for these drug treatments. And this provision alone, we believe, is bad public policy. Some tobacco cessation drugs are not safe for all people. A very popular tobacco cessation drug, for instance, is known to cause a whole host of side effects, including suicidal behavior. It's a great drug for many people, but for some folks it does not work and can be dangerous. Indeed, the FDA in 2013 linked this particular drug to over 500 suicides over a 5-year period. As a result, some plans do put that particular drug on the prior authorization list. So when we analyze a bill like this, we do have to ask ourselves whether my member plans are being asked to pay for the wrong care at the wrong time for the wrong people. And we believe this bill opens a door for that, and therefore we have to object. We also object to the language that further delinks counseling from the tobacco cessation drugs. My member plans believe that counseling sessions are an important part of tobacco cessation therapy and can enhance pharmaceutical therapies and maximize the chance of quitting. The data clearly shows that patients that receive assistance from a clinician are 2 to 3 times more likely to quit smoking for at least 5 months or more. So plans in the commercial market or in public programs are expected to be good stewards of either premiums or state funds. There is no provision here requiring the Department of Health Care Service to adjust the reimbursement rate to health plans for the enhanced benefit. So while we do strongly support the intent of the bill, we must vigorously defend the management of formularies if the cost of this benefit is to remain affordable to the state. So for those reasons, we respectfully oppose the bill. Thank you.
Thank you. Additional witnesses in opposition? Seeing none, any questions from committee members? Assemblymember Ridley Thomas.
Yes, Mr. Holden or Mr. Luizos. There are some concerns that have come up in the plan's criticism, and we see that there have been many bills that have come previously before us. Big problem. A comment first, and Mr. Luizos, I'm going to need your testimony as well, because I'm going to ask you for a solution here, or to help us work on some. The big problem is access to care across various communities. And it happens that in areas like one that I live in the Crenshaw District in southwest Los Angeles, where we have high rates of smoking and tobacco consumption, we have poor access to quality care. We have some of the worst ratios for healthcare providers per capita. We have a paucity of clinics and hospitals, and our health workforce is we have significant challenges with respect to health workforce. Wellness generally, I think the concept that I have, and I could be wrong, correct me, Mr. Holden, or the idea is that wellness saves money in the long run, and we want to encourage wellness, and the plans and Medi-Cal and society is better off if people are healthier and can live longer, be more productive, and be less sick. I think that's what this bill attempts to do. You can speak to that, Mr. Holden. Mr. Luizos, what are the constructive amendments that we can make here? Because the majority leader is trying to address a critical issue, and it's a real issue.
Right.
And saying, no, we must oppose, I understand from your perspective and what the plans are looking at in the total mix. But what can we constructively do to improve wellness, to get access to cessation services, use best practices, and improve community outcomes in general? From both of you, if you don't mind, the majority leader first, then Mr. Luizos. With your indulgence, Mr. Chair.
Well, let me just say, I think the whole idea here in terms of reducing costs is inherent in our proposal, certainly by increasing access to smoking cessation options, and also removing the barriers is the idea that we're hoping will reduce the health care impact on the other side. And certainly we believe that to be true in terms of lowering the costs. There were also some representations about in terms of the prescribing certain types of medications that are potentially problematic for certain patients. This is no different than any patient going to see a physician. The patient isn't going to prescribe their own medication, the physician will. And so we will know that the physician will be responsible for prescribing certain treatments that they believe will be appropriate and not dangerous to the patient.
Are you talking about the alternatives? Is that what you mean?
I'm responding to...
it's commentary. Okay, thank you.
Kind of lumping it all together.
Got it, okay.
Responding to your question.
Thank you.
I hope I did that. And then also responding to the notion that of the 7 prescribed approaches or medications, that there would be some that might be dangerous to some individuals. And we're just saying that a doctor obviously would be in charge of prescribing the medication.
Got it. And so cost, the thing that I get from that is cost is the underlying premise that is driving this, to improve cost by improving wellness.
That's correct.
Mr. Luizos, what is constructive? You may end up still opposing the bill for whatever reason, but what are constructive improvements to this bill if it is to move forward?
Well, thank you, Assembly Member. We're not going to be able to be supportive of a bill that eliminates prior authorization, particularly for a drug category that has known harmful side effects. And indeed, the Department of Health Care Services policy letter on this issue, which instructs the Medi-Cal managed care plans, does require the coverage of all 7 types of medications, but it says that only one has to be available without prior authorization. I think that's in recognition to some of the issues that I addressed in my primary testimony. So, my initial thought here is if the author and his staff were willing to sit down and talk about conforming the bill to the DHCS policy letter, I think we could find some constructive things to talk about. That would be our preference.
And that would arrest many of your concerns.
If there was conformity, that may or may not, that may address our concerns. Of course, I'd have to consult with my members. I have 43 member health plans.
You said how many?
43.
Got it.
Yeah. So with the majority of which do participate in the Medi-Cal program and are proud of that, that might be a place where we could at least start discussions. But at this point, the bill does not conform to that guidance.
Mr. Holden, does that at all, beginning that dialogue, is that okay to suggest, or?
Did you receive that in writing?
I did. Did we receive that in writing?
I think this is being videotaped, so I'm just kidding.
No, I don't know whether to qualify this as a filibuster. Or
got it. Well, the majority leader speaks to points we made about other commentary. I am sympathetic to what you attempt to bring, Mr. Luizos. If you can get us something, I'll try to speak with the leader. I would encourage you to do the same. He's a more than capable leader on all of these topics, and there's a reason why he brought it forward, because he actually cares. So I'll move the bill and hope that you can make sure that you get to him and really get those concerns out. And if things change or if it becomes less tenable from my perspective, Majority Leader, you know that I may not end up supporting it in its final iteration, but as a work in progress, because of your leadership and your competence on these issues, I have no problem moving it out of this committee.
I appreciate that, and I think it shouldn't go without saying that I'm always open to continuing to have dialogue, even when a bill is making its way to the floor.
Thank you, Mr. Majority Leader. We have additional comments and questions from members. We have Assemblymember Chavez, then Lackey, then Wood.
Real quick question. Thank you for bringing the bill forward. I noticed in the title of it, it's called Tobacco Cessation. You know, right now the big issue is vaping with nicotine. Was there any thought about expanding this to deal with nicotine, or are you just staying with tobacco?
I didn't catch the last part.
Vaping?
Yes.
That's what everybody does now, not old people like you and me that does cigarettes, you know, the young kids.
I don't smoke, but... Yeah,
neither have I. I'm just wondering, this deals with tobacco and vaping deals with nicotine. Was there any reason you focused just on tobacco and not nicotine and tobacco?
Well, would you like to...
Thank you, Assemblymember. Currently, e-cigarettes are not classified as tobacco products. That is another bill. We'd like to classify them as tobacco products and encourage those to also be included under that definition.
I knew it wasn't a tobacco product. That's why I asked the question about nicotine, because it is a nicotine product.
Nicotine product.
So if we'd have just added the word nicotine in here, is there a problem with getting people off vaping?
We'd have to, our major organizations are looking at the emerging science from longitudinal studies. We simply don't know the long-term effects of using electronic cigarettes. We know that nicotine is a harmful substance, and so we're worried about that. Lindsay, you want to?
Yeah, thank you. The nicotine in electronic cigarettes is derived from tobacco in most cases, so it's the same type of product, and the cessation from it would be similar. The folks who need to quit traditional tobacco could find the same benefits utilizing the FDA-approved cessation treatments that we have in the bill for quitting from the electronic cigarettes as well.
And I'll just add real quick that electronic cigarettes have not been tested by the FDA for safety and efficacy from cessation. So all of these treatments are already FDA-approved treatments for cessation.
I guess it'll be a bill for the next year. Okay, thank you.
Thank you.
Assemblymember Lackey.
Yes, let me just say real quickly that one of the great challenges that members of this committee face are trying to be humanistically and fiscally balanced. And as you well know, our healthcare system is fiscally struggling, and costs are clearly a stark reality. I'm definitely going to support it at this particular juncture, just because I know people personally who have died of lung cancer. I have friends who struggle with this addiction, and some that took a long period of time before they were successful in putting this behind them. So, however, the cost is a reality, and as Mr. Ridley Thomas has clearly pointed out, there is another side of this story that I hope that we can work this out, and if things aren't amended a little bit, I may not be able to support it on the floor.
Thank you, Dr. Wood.
Yes, and first of all, thank you for bringing this bill forward, Mr. Holden. I've been a longtime advocate against the use of tobacco for a number of reasons. So, my question actually is to Mr. Luizos, and I'm curious. The California Association of Health Plans, your member plans, do they offer this in the private sector to their members, or do they?
That is correct. Yeah.
But you object to it being offered to the Medi-Cal population?
It is currently being offered to the Medi-Cal population. What this bill does is remove prior authorization from the delivery of those drugs.
Does it require prior authorization with your other plans?
Yes, it does.
It does?
Yeah, as I stated in my testimony, in particular, there is one drug with potential very harmful side effects that some plans do put on prior auth, and that'll be deployed if those side effects won't be relevant for that particular patient. But yeah, it is something that is used in the private sector as well.
Okay, all right. I just want to be sure that for some reason that this population, which has a higher use of tobacco products, would somehow not be discriminated against because of the policy of the plans.
The Department of Health Care Services requires the coverage of tobacco cessation drugs. Our issue is that this is different than the policy that has been issued by the state, and in a way that we think is harmful. So,
thank you.
Additional questions from members? Seeing none. We have a motion. We don't have a second. The committee can entertain a second. We now have a second. We have a motion. We have a second. Would you like to close, Mr. Majority Leader?
Thank you, Mr. Chair. Let me just cite that the Centers for Medicare and Medicaid Services say that tobacco cessation treatments have a $2 to $3 return on every dollar spent. In the 18 months after a person quits smoking, they cost an average of $541 less per quarter than a smoker. We're trying to make a difference here, and I appreciate the committees recognizing that as well. As I said before, we continue to make ourselves available to continue to take input from those who have other positions on this to be able to strengthen this if we can moving forward. I respectfully ask for your vote.
Thank you, Mr. Majority Leader. The motion is due pass as amended to appropriations. Madam Secretary, please call the roll.
Bonta?
Aye.
Bonta, aye. Mainshine? Aye. Mainshine, aye. Bonilla? Burke? Burke, aye. Chavez? Aye. Chavez, aye. Chu? Aye. Chu, aye. Gomez? Gonzalez? Hernandez? Lackey? Aye. Lackey, aye. Nazarian? Patterson? Patterson, no. Ridley Thomas? Aye. Ridley Thomas, aye. Rodriguez? Aye. Rodriguez, aye. Santiago? Aye. Santiago, aye. Steinnorth? Aye. Steinnorth, aye. Thurman? Aye. Thurman, aye. Waldron? Aye. Waldron, aye. Wood? Aye. Wood, aye.
Thank you.
13-1.
The bill passes 13-1. Congratulations.
Thank you.
Mr. Cooper. Is Cooper still there? Cooper. Next, we have file item number 14, AB 1018, Assemblymember Cooper.